And yes, there are certainly a number of things that are done in terms of imaging cardiovascular disease with magnetic resonance. So let me start here. The image that's up right now is an example of an MR angiogram. It's something that was actually developed in my lab about 25 years ago. Really beautiful images. I'm sorry this is not a rotating view. Today you can put your 3D glasses on and watch this in a rotating perspective and look for narrowings or stenosis or even stroke for patients who have stroke in this case. So this really comes from a talk where we're looking at evaluating the brain from the fetus to dementia. So I'm going to go through some examples of some applications of this technology. In the last year, we have extended our work from the adult brain all the way down to the fetus, and this is an example of a fetus that's being imaged. On the left-hand side is just what we call a scout view, and the right-hand side is our first attempt to map out the venous information in the fetus. And the reason for looking at this is that even in the fetus, you can get hypoxic ischemic injury. That can come from a number of causes. And so wonderfully, we have the ability to monitor this in vivo. We can modify how we collect this data and try to zoom in on the data. So the difference between the first image, as you can see, the brain is very small here. In the second image, this is what we call a zoomed field of view. Each of these things that I'm telling you about represents an advance in the technology that's being used in MRI. This is a very recent result. We just collected this about 2 weeks ago, which is the ability to collect multiple slices through the brain in order to map out the vessels of the brain of the fetus, similar to what we talked about at the beginning for the adult. And if you strip away the rest of the womb and just look at the fetal brain itself, you can now begin seeing the vasculature of the brain very clearly. So we're quite excited about extending our technology into fetal studies. This next slide is an example of a child that's a few years old. Some of the technology that we've developed is now actually incorporated into companies like Siemens Medical Systems. This is an example of the technology here to look at a child who has a venous thrombosis. In this case, the normal imaging in the upper two pictures doesn't really show anything wrong at all. And in the lower left image, this technique is very sensitive to changes in the oxygen saturation. So if you have reduced blood flow and the brain still keeps functioning, it's going to extract a lot of oxygen and it's going to leave behind a lot of deoxyhemoglobin. And what we're finding is that the veins in this case become quite apparent, and that's because they have this increased level of deoxyhemoglobin. After the physician treats the patient with thrombolysis that basically gets rid of the clot, the blood flow returns to normal, and then you can see that the child's brain using the SWI actually returns to normal now. And one of our more recent goals, and a goal, for example, that's in a $2 million NIH grant that we have just applied for, is to quantify the amount of oxygen saturation. And if we can do that, that's going to have implications for studies like this. It's going to be very important for people who have stroke to know whether or not they're getting better, or if they're not getting better, why they're not getting better. And it has many cardiovascular applications as well, where you could have oxygenated, deoxygenated blood shunting from one side of the heart to the other. So these are things that have a lot of potential impact as they get developed. Another area that's a very hot topic today is traumatic brain injury. In the United States, we find that there's somewhere around 1.5 million to 1.7 million people affected every year with TBI. About 80% of those people are mild, and about half of those, the normal imaging techniques, they don't find anything wrong with the patients. And so this same technology where we can look at changes in deoxyhemoglobin give us the potential to see, is there any damage to the vasculature of the brain in traumatic brain injury? And we are finding out that roughly 20% of those people where we don't see something, generally we can now find that there really was something wrong. And the location of this damage can correlate with the cognitive outcomes of the patient. So if they have some attention deficit or some other problems, this may be related, for example, to frontal white matter damage. So we look at this type of study and we try to understand where the bleeding takes place. This particular case I'm showing you now is a stroke case. The conventional imaging on the right-hand side doesn't show anything wrong. And here on the left-hand side, you can see a small bleed in the area of the internal capsule and globus pallidus. So these are direct markers that will help the clinical community determine if there's really a problem or not, and hopefully then treat the patients better. Now moving on to a little more older people, this is an example of someone who has cerebral amyloid angiopathy. They have a mild form of dementia, and we're now finding that this technique lets us image these tiny, tiny little bleeds that are present. Let's call them microstrokes. And in this case, we can see very clearly that this person has many dozens of these small bleeds. And it turns out that even though this is a rather severe problem here, this individual is not doing too badly. And that's because these bleeds, they're separated far enough apart. They haven't all occurred at the same place. And so luckily the brain is a very wise vascular system that feeds each location from multiple sources. So as long as all of those sources don't disappear, then you can still function reasonably well. This is another new technology that's called susceptibility mapping. It's brand new in this field. It's an area that we have several patents in. And this technology is used to quantify how much iron is in the brain. Now, it's kind of interesting because we all rust as we get older, and we get more and more iron building up in different parts of our brain, such as the basal ganglia. And to be able to quantify that iron may be a way by which we can tell which people may have a proclivity for Parkinson's disease, for example, those people with trauma who've had bleeds, and other diseases such as Huntington's disease and thalassemia and diseases that have increased iron content. And this is an example that actually shows the traumatic brain injury. If you look here in the middle of the brain, you see the globus pallidus, which usually has a very high iron content. But in the upper part, you have multiple bleeds here that are shown by these very bright small white areas. Many times they're circular in their cross-section because they're like little spheres. If you look at the lower part of the brain, you can see many of these bleeds. The important part of this technology is that you can follow the patients over time and find out if the brain is cleaning up that iron or if there are new bleeds that are present. So this is really important for being able to follow the patient's recovery. Now, we've also used this method to look at iron content in diseases such as multiple sclerosis and Parkinson's disease. In this slide, we show a normal young person in A and a patient with multiple sclerosis in B. Both of these are the same age. And then again in C and D, a normal person in C and a patient, it happens to be an MS patient, but Parkinson's patients also look like this, showing very high iron content where the dark regions are. You might guess that this is also called the panda sign. It's kind of a nice little cross-sectional picture that looks like it has two eyes, which are the red nucleus, and the dark area is the substantia nigra. So this could be critically important for the new treatments where they implant sensors into the subthalamic nucleus for Parkinson's patients that can stop them from shaking and let them function normally. And one of the problems is they can't usually find the subthalamic nucleus very accurately with conventional imaging. The technique that we've designed here should make it possible to help the neurosurgeons know exactly where to put these new stimulating devices. Now, And another exciting area like this relates to epilepsy. And here I'm showing you an anatomy picture that shows the optic radiation, also called the radiatio optica in this picture. And then on the right-hand side, you can see the red arrows pointing to a very dark band that's basically comes from a stained cadaver brain. Now, the nice thing about MRI today is we can image the brain in the living condition almost as well as this picture you're seeing here in a cadaver brain. And one of the most important things when they're doing epilepsy surgery is not to cut into the area of the optic radiation, because this carries the information back into the visual cortex, and if you damage these fibers, then you may damage the sight of the individual or even blind the individual. So I don't believe people have figured out really the best way to do this yet. And so this same technique that I was showing you that is used now to study iron also seems to be able to differentiate the layers associated with this optic radiation. And here you can see from the yellow arrows, you can see two dark bands and a bright band in between it. This represents the tapetum, the interior and exterior layers of the optic radiation. And we can follow this quite far forward in this picture. So if we reformat this data, and don't forget in MR we collect three-dimensional information, so we have data from the top of the brain down to cover the whole brain. So we can look at it in one plane or reformat it into another plane. And these yellow arrows show you a dark band that runs all the way forward to the area of the midbrain that I showed you a minute ago. And this may represent the first opportunity to actually show the neurosurgeons this is where you don't want to cut the brain. So this would be a tremendous breakthrough, and we hope to make very rapid progress in this area in the next few months. So another area where we can use this is in studying the functionality of the brain. So those of you who are having coffee at the moment, I should tell you that when you drink coffee, you're actually reducing blood flow to the brain. So if you really are challenged from the point of view of blood flow or you've had a stroke, probably not a good idea to drink too much coffee. On the other hand, maybe we can get Starbucks to help support some of this research. So the image on the left here shows a lot of veins, the veins because they have this deoxyhemoglobin in them. And the image on the left is your brain without coffee. The image on the right is your brain with coffee. And if you look carefully at where the white arrow is, you can quite clearly see that you see more vessels than you did the first time. And the reason for that is because you've slowed the blood flow to the brain, but your brain keeps taking out oxygen. And so now it becomes more apparent that there is less oxygen available in these vessels. So that's why if you have stroke and you already have this reduced flow, you don't want to make it worse. Now, somebody asked here if this is at 1.5, 3T, or 7T. This particular image is from 3T, but you can see the same thing even at 1.5T. You just have a little bit better signal to noise at 3T. And at 7T, we can image this even better than here. 3T, we usually use a resolution of 0.5 millimeter by 0.5 millimeter in plane. And at 7T, we can use 250 microns by 250 microns. So you can see even more vessels if you do this at 7T. In fact, some people at 7T now claim that they can see microbleeds that may be associated with Alzheimer's disease, for example. Now, we've developed another new technique that we call susceptibility mapping I mentioned before. And the image on the left is this normal, very exquisite SWI image showing the contrast for the vessels. But the image on the right is a quantitative map of the iron content that's in the brain. So these veins have a lot more iron content than the background with respect to the deoxyhemoglobin. And so we're interested in using that technology to finally not just qualitatively say there's a problem, but quantitatively say there's a problem. We can also use other methods called perfusion imaging. And perfusion is really a wonderful technique. It's used a lot in stroke. It's a means to measure the cerebral blood volume, the cerebral blood flow, and the delay time of the blood getting to different parts of the brain. So in that particular case, if there's a significant delay, you will see this for stroke patients. One example of stroke using the SWI technique is shown here, where diffusion-weighted imaging on the left shows that there has been a stroke, but the SWI shows these very dark vessels. And now that you're all experts at understanding that this is from deoxyhemoglobin, you can see this stroke patient is not doing very well on the right side of the brain. Remember, this is actually, it's the left side of the picture, but it's the right side of the brain because you're facing this person when you look at these pictures. You can also see with the susceptibility mapping that the vessels are much brighter here, and that means they have much higher levels of deoxyhemoglobin. So this is a bad case where the patient, even several days later, has still not recovered the normal levels of oxygen saturation. Now we can move on away from the veins, focus a little bit on the arteries. So this is a technique that lets us image the major arteries, and of course we want to look for stenosis in these arteries. And if there's a stenosis, maybe we can do something about it. And we've been further developing this technology for people who want to do endovascular stroke treatment, so that we can image down to about 250 microns, even at 3 Tesla. And this is important because you want to guide the surgeon to where the damaged vessel is so that he can go in and pull the clot out. And if it's a major vessel that's damaged, it's even more important to get the clot out because perhaps the antithrombotic agents may not work so well for them. So the upper image is actually, no surprise, a cadaver brain image, and the lower image is really our first attempt at this 250 micron resolution data. And you can see that even though these are two different people, and the volunteer below is still alive, I promise you, you can begin to see these vessels really quite beautifully. So the day is coming when we'll really be able to evaluate the vasculature for all people like this. Now I'm going to switch topics and leave the brain a little bit because we've discovered what may be a critical new advance in studying multiple sclerosis, Parkinson's disease, idiopathic intracranial hypertension, maybe even migraine and headache. A fellow in Italy named Professor Paolo Zamboni, about 4 or 5 years ago, discovered that people who have neurodegenerative problems also have a problem with obstructed vessels in the neck and in the spine. And he found that multiple sclerosis patients particularly tended to have narrowed jugular veins. So just like with atherosclerosis, you have narrowed arteries, with MS and Parkinson's and other diseases, they're now finding you have narrowed veins. So this has opened the door to interventional radiologists going and trying to fix this. To my surprise, in the last 3 years alone, 20,000 people have been operated on for roughly $10,000 a person. So you're looking at $200 million of business based on this observation of Paolo Zamboni. But that's actually a very small fraction of the potential business here, because there are roughly 2.5 million people with MS in the world. There's 5 to 10 million patients with Parkinson's disease, and there is an innumerable amount of people who have headache, from migraine to all sorts of other headaches. So the question then is, how many of these people are actually suffering because they have bad vasculature? This is a completely unanswered question today, and something that our group is pioneering. We have now collected for study over 2,000 MS cases. We're now starting to collect Parkinson's and headache cases. And we believe that this is the next generation of care for people who have neurodegenerative disease. So to show you an example here, you can see in this individual on the left, a very narrowed jugular vein. And the individual on the right, the jugular vein is narrowed throughout the entire neck. A few more cases, these individuals, if you look at image C here, you can see that the jugular vein comes down and basically stops. So what happens to that blood? The brain is trying to get the blood out, but it can't get the blood out. So it shunts that blood back up and back out other vessels, small vessels that run down the spine through the other big vessels like the right internal jugular veins. But this is a very inefficient way to do it. So Dr. Zamboni believes that this creates a chronic venous hypertension, which eventually leads to neural disease. So that the white matter begins breaking down, you get lesions, and then you get all the cognitive effects that go with that. Now, I didn't mention, but I should tell you that out of these 20,000 patients who have been treated, not all of them get better, but some of them do. I think the current belief is about 1/3 of those patients are now much better off than they were before. About 1/3 of them are really only a little bit better, and the other third really haven't benefited from it. And that's probably because we don't really understand yet that the vascular problem is really a problem for all the people. It may be that only 1/3 of multiple sclerosis patients really suffer because they have bad vasculature. They may also have a vitamin D deficiency. They may have had Epstein-Barr virus. They may be hit by multiple things. Maybe they have other genetic factors. So you may need to have all of these factors together to understand what's happening. Well, I have to tell you, I think MS right now MS alone is a $10 billion a year business for the pharmaceutical companies. The pharmaceutical companies have not yet got involved in this research, but it would be a way for them to subcategorize their patients and say, look, maybe the patients who don't have vascular disease recover much better with our drugs than those patients who do have microvascular disease. If that's the case, this is a gold mine for the pharmaceutical industry. And it's just there waiting for them to discover it at the moment. And hopefully with seminars like this, with the opportunity to present data like this to the pharmaceutical industry, they will eventually realize that MR opens the door for them to investigate these questions. Well, we're actually coming along to close to the end of the talk here. This is an example image that if a neuroradiologist looked at it, he would say, oh, this guy's just fine. Look at all those wonderful veins. There's not a problem. But you can't tell by looking at it. You have to measure the blood flow inside the veins. So the wonderful thing about MR is that in 2 minutes, I can take a cross-section through the neck and see all the vessels that you see in the upper left image. In the middle image, I can actually create a picture that is directly related to the blood flow at every point in that vessel. And on the right-hand image, we then demarcate all of these. Now, I'm happy to tell you, we just got a $1 million grant here this week to further develop the technology behind all these methods that I'm talking to you about. It's a 2-year proposal so that we can create this type of software as basically a push-button technique that can be used so that anybody can do this measurement. And you can see here on the left-hand side, this is a plot of the flow as a function of the cardiac cycle. So we take a picture about every 40 milliseconds, so 25 times in a heartbeat. And we measure the blood flow throughout the heartbeat. And you can see that the red, which represents the arterial flow, looks very good. But on the blue, there's only one of those veins, just one of those veins that's carrying a significant amount of blood. So you can see this is a highly abnormal situation. Hopefully all of you who are listening to this talk today will not have that problem. You will look normal and your blood flow will be normal. And to really demonstrate how much of a problem this is, the blue line with the little circles, the open circles in it, the light blue line, you'll notice it flows like an artery in the first half of the cardiac cycle, and then like a vein in the second half. And what that means is that the blood flow is trying to get out. It can't get out, and it flows back up into the brain. And so every time this person's heart beats, he gets pounded by a hammer on the inside of his brain because that blood can't get out, and it has to find an alternate pathway out. So this can create a lot of problems. In this particular example, I'm showing you a case now, someone who has headache, and you can see that he's pretty much missing the flow in the left side of the transverse sinus and sigmoid sinus. And here you can see these same highlighted veins I showed you for stroke now show in this person with headache. This is not good news. This means that there is reduced perfusion to this tissue for that individual. And to my knowledge, this is the first time this has ever been shown on somebody with headache. And finally, I'm going to close just to show you an example with Parkinson's disease. And here you can see something very similar with this individual with Parkinson's. He has a lack of flow in the left side of the brain. And I'm just going to skip ahead a little bit here to this plot. And in this plot, I show you three abnormal categories. Category 1, 2, 3 all have bad blood flow. And category 4 has normal blood flow. And out of the 21 Parkinson's patients that we studied here, and I just presented this in Poland a few days ago, and we have a presentation at the International Alzheimer's and Parkinson's meeting in Florence, Italy in 2 weeks. You can see that a total of 15 out of 21 of these Parkinson's patients has abnormally low flow. And when I do this for normal people, I find that only 4 out of 26 show that same effect. So 22 out of 26 people sit in the normal category, and only 6 out of the 21 Parkinson's sit in the normal category. So we're hoping that this may lead to new treatments for Parkinson's disease. It's something that we're just getting started on, but would never have been possible if we hadn't developed the technology to go with this. So let me just stop there for today, and hopefully I've given you a good idea about how critical it is to have a thorough study with magnetic resonance imaging to study the flow, the blood vessels, iron content, and of course anatomy. And at this stage of the game, I'd like to stop and see if you have any other questions. And feel free to type in anything here, and if not, thank you very much for joining us today. And of course, if you have other ideas in the future, you can certainly contact us by email. So do we All right, there's a question that has come in here about phase contrast flow. Yes, it is synchronized to the ECG. In fact, in this case, for many of these subjects, we just use the pulse trigger. It's more accurate to use an ECG. It will do a better job than what I showed, but we get generally fairly consistent results. And for many of the people who interact with neurologists or neuroradiologists, to add the flow measurements and to add the imaging of the blood vessels takes only an extra 10 minutes over and above conventional imaging protocols. And I think actually I also want to add here for you a website I would like you to look at if you're interested in this concept, especially, you know, most of us know somebody who have you know, family who are affected by this in one way or another. So these are two other websites different than mrinnovations.com. And then also you can contact my administrator, Rachel, and I'll give you her email here if you have any questions. And yes, a question from one of the people about the ability to do ECG. Yes, please feel free to contact Rachel, and we can always set up a personal phone conversation to discuss these types of things. All right, any other questions we missed up here? How long is normally typically a swim measurement? Oh, the SWI scan is something that can be run just once. It takes about 3 minutes on a 3 Tesla scanner to cover the brain. It's now implemented in more than 1,000 scanners around the world. We then do the swim processing directly from the SWI data. It's perhaps one of the most powerful imaging methods available today. Very good question. Yes, the resolution we usually use is 0.5 millimeter by 1 millimeter by 2 millimeters. So it's 1 cubic millimeter. And there's another question on what stage of Parkinson's patients. Yes, these patients were 62 years average, plus or minus 8 years. The volunteers were age-matched volunteers we did to study. They had quite a variety of ratings. We used the United Parkinson's Disease Rating Score, known as UPDRS. And to our surprise, because this is rarely true in the imaging, to our surprise, we found that the amount of white matter hyperintensity correlated with the disease, and we also found out that there's a correlation with the abnormality in the flow. So, Jam, good to hear from you, and thank you for that question. Jiao Yansang, I think the answer to your question is that it is in some places. We have several sites in China who are collaborating with us, and the wonderful thing about the Chinese is they do in about 3 months what it takes 3 years here. So we just finished a study on stroke in Tianjin with about 125 stroke cases, and we can quite clearly correlate perfusion deficits with the swim results. Again, thank you very much, everyone. I think we'll close it for today. And again, if you have further questions, don't hesitate to contact us. And we'll look forward to our next session, hopefully in around a month from now. Thanks, and have a great weekend, everyone.